This is the Research Room.
Hello.
Hello.
Welcome to the Research Room with me, Lucy Ather.
And me, Janine Healy.
And today, we're not actually in the Research Room.
I know.
We've left. We're at the NIHR Applied Research Collaboration for Yorkshire and Humber.
At the Milner Hotel in York.
We're on the road.
You can hear all the
buzz
before
that we're at this event.
And it's making the journey from treatment to prevention in mental health services, the NHS 10-year plan.
Yeah, so we're here to learn all about mental health research that's going on, and we're going to be interviewing people here at the conference. And yeah, I'm excited.
Oh, so am I.
So I'm here with Professor Simon Gilbody, and you're the keynote speaker of today's event. So could you tell us a bit about the event and what we're doing here today?
Very good. So we're really pleased to be here. So we're in the wonderful city of York, and we've got a day today that's all about prevention in mental health. And historically, prevention is not something we thought about in mental health services. You know, mental health services are often busy, what we say firefighting, so dealing with all the challenges of ensuring that we've got really excellent mental health care for people who use the NHS. But the NHS is on a journey just at the moment. So Wes Streeting, the Minister for Health, has told us that the NHS is going to make a historical transition from treatment to prevention. And we think that's interesting and welcome, but it raises lots of challenges. So we wanted to get together in York today to think about that within our ARC, the Applied Research Collaboration. So we're here today. We're going to think about prevention, what that means in mental health. And there are two things that I think are important for me. So the first is that it's really challenging, but desirable that we move from treatment to prevention in mental health services. And if we can prevent things like depression or anxiety, that'll be a good thing, because they're some of the main drivers of economic inactivity, and they're the main causes of disability within the population. So we've got some good strategies that we're going to speak about today. And if the Health Minister is listening, then we've got some good messages. The second thing is that people who use mental health services experience profound health inequality. So if you have a diagnosis, something like schizophrenia or bipolar disorder, your life expectancy is reduced by between 15 and 20 years. And that's really important. So we want to look at that through the lens of prevention. So those are the couple of things that we're going to think about today here in this really exciting day. So looking forward to it.
Yeah, great. No, I think that sounds amazing. It's going to be a really good day. So do we have people coming? Obviously, it's the ARC, you mentioned, yeah. Yorkshire and Humber. Is it all about Yorkshire, or do we have people from all over today?
Well, as we know, Yorkshire is the known centre of the universe. So we've got lots of work that happens here in Yorkshire and in the Humber. So we've got people from within the region and within the ARC, but we've also got people from all over the UK, and particular from several of the other ARCs that are here in England, and we have got really great representation. So we want to start a conversation and be at the centre of that conversation and lead that conversation, and to work in partnership with our colleagues from other ARCs to think about this transition from treatment to prevention. And we think we've got a lot to say, and we've got speakers from all over the UK today. We've also got some speakers from here in God's own county, Yorkshire. So this is all very exciting.
Well, yeah, we're really looking forward to a great day, and we'll catch up with you later.
Welcome to the Research Room.
Thank you very much.
Can you tell me who you are?
My name is Kate Robinson, and I am the Knowledge Mobilisation and Communications Lead from the NIHR Applied Research Collaboration for Yorkshire Humber and Bradford Institute of Health and Research.
Oh my goodness, that's a big, long title. I'm glad you can remember it.
Yes, it is a bit. I could sort of break it down a little bit. So we're really interested in knowledge mobilisation in the ARC, which is kind of why we're here today.
ARC. You can explain what ARC is.
Oh, yes. So the Applied Research Collaboration for Yorkshire and Humber, so you've got lots of different NIHR infrastructure, so the National Institute for Health and Research. Yeah. So across the country, there is loads of different types of NIHR organisations, and they all do slightly different things. So it's like the Research Delivery Unit network that have lots of research nurses and midwives going out and doing clinical trials in hospitals. You've got the Research Support Service, you've got the Biomedical Research Centres, all sorts, and we're the Applied Research Collaborations. So we concentrate on doing applied research. So research that's really relevant for our local communities, that is in the sort of phase where we're kind of testing it so we can put it into practice really quickly. And the one thing that the NIHR really want us to do is make sure that our research gets into practice. So what we're actually doing day-to-day research-wise, we can then offer to system partners, integrated care boards, primary care trusts, and say, we know this works and we think this could help your patients, help your local communities, save you some money. But the idea is that our research gets put into practice.
Oh, okay. And what is this conference about?
So part of my role as knowledge mobilisation lead is I need to be the person that tries to work out how to bridge that gap between research and practice. So how do we get our research to those people that can actually do something with it? I always say that, our researchers have world-changing ideas and they never end up in the hands of people that can use them. A lot of the time research sits in dusty books. I think there's a really crazy statistic that 7,000 research articles are published every day, but only about 50% of them are ever read.
Really?
Yeah, so that's a massive problem, isn't it? Because within those research articles, there will be amazing ideas. So this is where the concept of knowledge mobilisation comes in. How do we get those recommendations from research to the people that need it most? And to do, there's loads of different ways of doing it. And one of the best ways of doing it is to hold an event.
Oh, I see.
What I would love to see at these kind of events, and the kind of people that we target, are people that can use the research. So frontline staff from the NHS, people from the integrated care boards, people that are making those decisions daily about what services to commission in our health and care system. I want those people in the audience, because those are the people that can listen to that research and think, that's a really good idea. I'll go and speak to those researchers afterwards. So that's why we're here today. We're here because we've got all that research and we just want to be able to tell the right people about it. So it's not a conference about doing more research. Although obviously there's a place for having a large amount of research as an evidence base. That's really, really important. But really, we've done the research, so now we need to mobilise those recommendations. So events like today are absolutely perfect in bringing the right people together to be having those conversations and get that research used.
The more people talk and collaborate, the better it becomes, doesn't it?
Absolutely. And that just goes to show, isn't it? Again, there might be research that in dusty books in the university that you don't know about, and that can make a real difference to people's lives. And I do knowledge mobilisation training, and the information about that is on our website, for the ARC website. If anyone wants to come, anyone's welcome. But I always say, like I've said before, there's those world-changing ideas that are sat there, and we need to get them to people, and they really do make a difference. I ask everyone at the start of the training why they work in research. We do a little bit of a Slido, I don't know if you've seen them, where you scan a QR code and
Yes. Yeah.
So I say to people, why do you work in research? And the more people put in a certain thing, the bigger that gets. And the biggest thing on the slide afterwards is always making a difference.
Yeah, making a difference. That's why we're all in
That's
research,
why we're getting up in the morning. And I always say to them, well, how can we make a difference if our research doesn't go anywhere?
Yeah. Oh, brilliant. That's a good ending. Thank you
Thank
very
you.
much. Thank you.
Professor John Wright, welcome to the research room.
Hello, Lucy.
So we're here today to talk all about prevention. Could you tell me a bit about why prevention is so important?
So we've been running a study called Born in Bradford for the last 20 years. Started very much on the treatment clinical side of it, gestational diabetes and genetic disorders, that sort of stuff. Fairly quickly after we started collecting the data, as the children were growing up, we realised there were these diverging pathways for these children, whether it was education or health. And it was a wake-up call to us to how important changing those trajectories were, particularly around the poorer kids, and how early life interventions were important if we were going to ensure that these children grew up to be healthy adults. So it really focused our minds on what we can do to prevent ill health later on.
Yeah. And Born in Bradford, that's a massive study. I've definitely heard of Born in Bradford. Could you tell me a little bit more about Born in Bradford?
Yeah, well, it's one of the biggest health research studies in the world. We have over 60,000 participants, over 30,000 children and young people.
Amazing.
And they're now, the oldest ones are teenagers now, just leaving school. So we're very interested in looking at the life course from when they were born to what's happening now with who's going into college, who's going to university, who's going to work, who's not going into work. And that's one of the key government priorities, the not in employment, education and training. And we find that we can track these children from a young age to work out who's at risk later on. And the trick then is, can we intervene to do something early on to stop these children falling down abysses?
But you've been following them since they were born, since they were babies?
Absolutely, before they were born, with their mums, yeah. When they were
Oh,
still
wow.
in the womb.
And we're obviously here talking about mental health. So is it just mental health that you look at, or mental health and physical health?
Yeah, we're interested in mental health, physical health and education and life chances fundamentally. You know, one of the things about this country, it is an unequal country, unfortunately, and that inequality, from what we know in Born in Bradford, starts young and gets worse as the children go up. So it's very much around both of it. Mental health's the key thing for us at the moment. We've got 30,000 teenagers involved in the study, so a big thing for them is less about physical health and more about the mental health, depression, anxiety, loneliness. And so we're looking at, firstly, measuring it and understanding what's causing it, such as screen viewing or social media, but then also developing interventions that we hope may reduce it later on. Yeah. So we're doing the world's first randomized controlled trial of social media restriction, which is starting next month.
We'd love to maybe get you into the research room for a proper episode about that.
Very happy to do that.
Excellent. Oh, well, thank you so much for talking to us today.
Pleasure, Lucy.
Great, thank you.
So could you just introduce yourself for our listeners?
Yes, so I'm Dr. Ruth Wadman. I'm an Associate Professor of Children and Young People's Mental Health at the University of Bradford.
Lovely, nice to meet you. And could you tell us what the name of your project is that you're presenting today?
So the name of my project is the PPAMH, which stands for Promoting Positive Adolescent Mental Health for School Climate. So it's a feasibility trial of a school-based intervention.
Brilliant. I really like that acronym as well. So could you just tell us a bit more about the project in sort of a nutshell?
Yeah, so we were keen to find new interventions to introduce in Bradford, and working with an international expert advisory group, we identified essentially a suite of interventions that had a growing evidence base but had yet to be tested in Bradford. And then we worked closely with a group of young people in Bradford who prioritised which intervention they felt was most appropriate, and they picked the PPAMH intervention. So that's how we ended up with that intervention.
So it was really sort of co-produced, I suppose, with the young people. Yeah. And could you tell us a bit about why you're doing this project, a bit of the background, sort of what you're trying to address, challenge and solve?
Yeah, so I think we all realise that there's a growing mental health crisis in our young people, and despite 20 years of efforts to reverse that trend, things haven't improved and in fact have been getting worse since the pandemic. So I'm very motivated with finding new and different ways to try and improve and protect young people's mental health. And we're quite keen to think about how schools can support that, because young people spend, a huge amount of time in schools. It's where they spend the majority of their life outside of home. So if we can find ways to make schools essentially mentally healthy environments to be in, then hopefully that would improve and protect young people's mental health. So the PPAMH for School Climate reflects that in terms of the term school climate, and it's a multi-level intervention, so whole school approaches, group work, and also one-on-one signposting and referrals. And the idea is to create a sense of belonging, to give students a voice in school decision making, and to improve relationships both between staff and students and within students as well. So essentially, how do we make this a nicer place to be in is the question. Yeah.
Wow, that sounds brilliant. I think it's such an important thing, isn't it, the environment that people are in and that influence. So what's come before this project, and what do you anticipate coming next?
Great. So this project, the PPAMH intervention, was actually adapted from another intervention that was developed in Bihar, India. And we worked with groups of young people and students and staff in schools to adapt the intervention to suit Bradford secondary schools. So what we're doing in this feasibility trial is essentially seeing if it works. Is it acceptable? Does it need to change? So we'll be doing an implementation evaluation and also continuing PPIE work with children and young people, so that hopefully we will progress to a full RCT in the future across Yorkshire's secondary schools. So that's the aim. It's also a bit of a global phenomenon. It's gone global. So I've spoken to researchers in Tokyo, in Brazil, in Barbados, who are all trying to implement a similar intervention in those parts of the world. So there's a real international interest in this approach. And it's quite a low-tech approach. You know, it's not digital. We're hearing a lot about digital stuff, but it's having things like a notice board and a speak-out box, so you can put suggestions in it. And then it's about talking. So, yeah.
Oh, wow. Well, good luck with that. Thank you so much for speaking to me today, and good luck with your presentation.
Thank you very much.
So I'm here with Amy and Kim. Thank you for joining us today, and you're going to tell us all about your project. You're here with a poster. So could you just introduce yourselves for us?
Thank you very much for having us. Yeah, so I'm Amy. We're from TendVR. I work within the research and grants applications. So my job is to oversee all of our live research projects that we have. We have a few going on at the moment for funded opportunities, and I'll hand over to Kim.
Hi, and I'm Kim Bevan, and I'm the head of clinical and research services at Tend. And I tend to be the principal investigator on all of the research studies that we do, plus a whole load of other things, because we're still classed as a startup. So we've all got to chip in with everything, really.
Brilliant to have you both on our podcast. So could you just tell me what your project is called?
So in terms of our project, it might be a good idea just to give you a little bit of context about what our product is really overall. So TendVR, we work within the mental health space, and we've adapted a mindfulness-based cognitive therapy program. So it's a mindfulness-based informed program using virtual reality. So really founded in the core principles of mindfulness-based cognitive therapy, but adapted for use with a virtual reality program. So we've adapted the fundamental parts of that training program, which is usually delivered online or face-to-face in a group setting for use of people that might find that a little bit more challenging. And we've developed it over an 8-week course, so individuals would have a weekly session around about 40 to 45 minutes in the virtual reality headset, very immersive, full of interactives and activities, as well as psychoeducation about improving their mental health overall, but with a specific focus on symptoms related to depression and anxiety.
And we've done quite a lot of research to look at the feasibility and acceptability and look at if there are any signals of efficacy for what we're doing. Because obviously we wanted to work from an evidence base rather than just to try to sell our product out there, which is not the approach that we take. So we've done 5 feasibility and acceptability studies with great results, definitely feasible, definitely acceptable in a number of different circumstances. And we do find very strong signals of efficacy as well. So our next step will be to do a randomised control trial, so that we do a full clinical trial as well on a large scale. So we've currently doing some work with difficult to treat depression, but we've worked with a whole load of different cohorts of mental health patients, and we're also delivering in the NHS at the moment to the service in North Yorkshire. So it is available on the NHS in North Yorkshire as well. So the results are looking great, and we've got some really good feedback. We always use a co-production approach as well, so we have a lived experience advisory panel who work with us on all of the work that we do. It's not just the research, it's also any development work that we do too.
It's really important, I think, to involve the patients in your work. Yeah. Fantastic. So it's a virtual reality headset, or I suppose a virtual reality program that you use wearing a headset. Yeah. Oh, fantastic. And could you tell me a bit about the background of the project and where the idea came from and why this is a good idea, really?
Yeah, absolutely. So the sort of idea of the project from our founder, Matthew Hodes-Brodson, really comes from a place of lived experience. So growing up with a mother with mental ill health and what impact that had on him and his early development and into adulthood, really. And
a lot of the team that we work with, our multidisciplinary team from the non-tech team, which myself and Kim represent today, but also the tech and the development team, come from a place of lived experience as well. So we really bring that in part of our product development, as well as we've already said, speaking with the crucial involvement that we have from all of our lived experience advisory panel. And we should say as well as having kind of an overarching lived experience advisory panel for any obviously new research projects that we embark upon. There's a specific LEAP developed just for those, and they've really been fundamental actually in terms of the developments that we've been able to make and make it more meaningful for the people that are going to be using the product. And I think we bring the lived experience as team members to the work that I do. And I would say really, although it does sound cliche, it gives us the why. You know, it's the reason why we're passionate about the product. And some of the developments that we've had, I've been working on projects for the past sort of 5-6 years now, and it's really been amazing to be part of the evolution of that. One of the things that is a recent addition to the product that we can give people that have meaningful change to their lives is a mobile companion app. So we recognised really quite early on that whilst the virtual reality programme was actually pretty life-changing in some circumstances for people, it was also almost in isolation for the virtual reality. And the mobile companion app is really the bridge by which people can apply what they learn in the virtual reality programme into their real life and take with them really in their daily practice. And we're very excited about a new development that we have coming with that.
Yeah, no, fantastic. It sounds really exciting. So you did mention a randomised control trial, which we love here in the research room. Is that something that's going on now, or is that a kind of future project?
So it's a future project. We're just gathering our data at the moment. We're doing a pilot RCT so that we can just lead straight into it really. But we will be applying through one of the research grant routes by the middle of this year. And we know that that's the next step for us. We've got to get that robust clinical data. We've got lots of signals of efficacy, but it's just having that where we can say, actually, this is significant. So that's what we're looking for at the moment. But we definitely are going to do an RCT by the end of the year, provided we get the funding, which, we hope we will.
Oh, perfect. Well, best of luck. I'm sure you'll get the funding. That'll be great. And I'll look forward to hearing all about the RCT when it definitely happens. Thank you very much. Thank you.
So could you introduce yourself for our listeners?
Hi, my name's Dr. John Pickavance, and I'm the trial manager for the IRL trial.
Nice to meet you. So what is the name of your project? You just mentioned IRL.
Right, so IRL is in real life, and it's a trialling real life among 12 to 15-year-olds. So the idea is we're going to try and get them off social media, or at least restrict the access they'll have to it, and see if it makes any difference to their mental health and well-being.
Brilliant. It's very topical at the moment, isn't it? So could you tell us a bit more about the project, sort of in a nutshell? In a nutshell.
So this has been kind of percolating for the last couple of years, and it's at the request of our young people. So we work very closely with young people in Bradford, and we said, what do you want us to look at? What kind of questions do you want us to answer? And they said, well, our parents and teachers tell us that social media is bad for us, but what does the science say? And it turns out the science doesn't have very much to say. There's lots of kind of correlational studies that are poorly controlled and, have methodological limitations. So we said, okay, well, we'll go out and do a trial and try and get an answer for you. And like I said, that's been in the pipeline for a while now, but obviously in the current political climate, it's kind of taken on a life of its own, and everyone's, really interested in what we'll find and how it'll go.
Brilliant. So where are you up to in the trial at the moment?
Right, so we're currently, we finished our development of the protocols and the intervention, which is a smartphone app they'll be installing on their phones. And we're about to feasibility test it in a single school in Bradford. And then the idea is we'll scale that up from our learnings, and in September of this year, so next academic year, we'll do the full-scale trial. So hopefully we'll have it all wrapped up before the end of the year, and any potential bans that may come in.
Exciting stuff, and I think that people will be really interested in it because it's so topical and people will be wanting to know those results. So could you tell us what the next steps are and a bit about sort of how many people you're planning on recruiting and schools and things like that?
Right, so we're going to be recruiting 4,000 young people between the ages of 12 and 15. which represents the first fully powered RCT looking at social media restrictions in healthy adolescents, which is presumably why so many people are interested in it. And they'll be split across about a dozen schools. It's actually going to be a cluster trial, which means it's randomised at a group level. The unit of analysis is going to be the year group at the schools. And the reason for that is the exposure operates at a kind of group level. We don't think it's enough just to take random kids off social media or restrict their usage without the kind of effects of those around them being on it, contaminating them in some way. So that's why we're doing it as a cluster trial. And that's going to be, so 36 year groups in total over 6 weeks. And then, we'll compare those year groups where they were limited to either 1 or 2 hours a day and then without access at night. And then we'll compare those to who had no restrictions and see, what the difference is on baseline and follow-up outcomes such as anxiety, depression, well-being, and then kind of secondary outcomes like, the physical activity, the sleep, and cyberbullying, all these other kind of things that might have a role.
Amazing. Well, good luck with that. Thank you so much.
No, it's a pleasure.
Are you doing a presentation at the conference today?
I am. Thank you very much for the practice.
Perfect. Thank you so much.
So, could you please introduce yourself to listeners?
Okay, so I'm Dave McDaid. I'm Associate Professor of Health Economics at the London School of Economics.
Okay, thank you. And do you want to just tell us the title of your project that you'll be talking about today?
Well, I was talking really about making the economic case for investing in prevention. Is there an economic case, and how do we make it, essentially?
So, because prevention, that would be a long-term result, wouldn't it? Wouldn't be an immediate one?
Well, that may be a bit of a myth, because I think sometimes, of course, there are long-term benefits for many interventions, but often there are also actually short-term benefits within a year, maybe 2 or 3 years, and I think we also need to highlight those benefits more, because then they open the door to having services in place to get the longer-term benefits.
Perfect. Okay, thank you. And could you tell us in a nutshell a little bit more about what you do as well?
In a nutshell, that's quite challenging. I'm involved in many different areas of mental health research, where really what my role is to really try and essentially what is the economic case, what are the important impacts, how can we put a value on them. So not just the impacts and the value to the NHS, but to other sectors that deliver services, to people with lived experience as well, what's important to them and how to value that, and then to try and present that evidence in a way that's accessible to policymakers.
Wonderful. So what do you feel about this event today?
It's very well organised, very nice hotel. But I think it's, from a serious point of view, I think it's really good to get a lot of people in a room to think much more about prevention, to take it more out of the shadows. It's quite easy for government strategies to really be paying lip service to things, so it's about really transforming into action. And the more we can actually concretise, that's not a word, but anyway, really make something solid, to say there's an evidence base there, the things we can do, there are challenges, but we can provide solutions as well. I mean, you can't do that unless you have meetings where you talk to people and think about solutions. But I do think just generally, some of us today have made the point about the large impacts that poor mental health has on life expectancy, and not just for people with severe mental illness, but also people with more common, so-called less severe conditions like depression. Big differences, and we don't do enough about that, so prevention can help with that as well.
Okay, thank you for your time. Thank you.
You're more than welcome.
Hello, welcome to the research room on the road. Would you like to introduce yourselves, please?
So my name is Scott Weish, and I'm a psychiatrist and Professor of Mental Health in the University of Sheffield.
And hi, I'm Joe Hulin. I'm a Research Fellow at the Mental Health Research Unit at the University of Sheffield.
Welcome. And you're going to talk today about your project. Could you explain what it is and the title?
Well, I'll let Joe start.
Yeah, sure. So we're here today talking about our ongoing work looking at suicide prevention in primary care. So we're speaking a bit about why we think primary care is an important place to focus suicide prevention efforts, and talked a bit about some of the challenges facing GPs, and also covered some of the work in terms of some of the challenges GPs face in identifying individuals who are at risk of suicide, and the type of support which can be offered to those individuals.
Okay, and unfortunately I didn't get to listen to your talks, so could you tell me how are you going to do this?
Well, we don't know yet, but I guess there's two main elements we're looking at. One of them is looking at how we can enhance integration of primary care with other mental health care services, so we can streamline pathways to more urgent support for individuals who are in crisis, and also linking with VCSE organisations to see how we can strengthen links between primary care and VCSE organisations, because they play an important role too in addressing some of the social and economic factors which may impact suicide. And the other aspect we're looking at is how GPs can identify and assess risk in primary care, which is a bit of a contentious issue.
Is there a reason why you've chosen primary care?
Yeah, so primary care is a really important place to work to try to reduce that suicide or to try to prevent suicide. We know that around 80% of people who end their lives by suicide have consulted in one way or another in primary care in the year before they end their lives. So it is the place where we think that there's going to be huge benefit and return. Unfortunately, many years of research in trying to do just this have really not succeeded. Mostly that research has involved trying to train GPs to do things differently. We think they already do a really good job of working with people who are emotionally distressed. The difficulty is spotting the one person amongst all those people that are in difficulty who might go on to end their life by suicide, and then making sure that they get the help they need in the way that they need it. There's another really big problem in this area, and that most people who do end their lives by suicide are in a group identified as being at low or medium risk, because that's the nature of it. There's just a lot of people that think about ending their lives, and very few people go on to do it. So trying to find that needle in the haystack, trying to find that one person who really needs urgent help can be really difficult. We think also, as well as responding more quickly, we think finding better ways to spot those problems and spot that risk before it happens, possibly using more advanced data science methods like machine learning and AI, might help give GPs the information that they need to do an even better job of caring for people. So we're calling what we're doing improved decision support.
I see. So basically, you're hoping to use something like AI and data basically to help you.
People have been researching using these models, looking at what we know about patients, looking at their records to try to use AI, and it works to a degree, but there are limitations. But I'm going to let Joe say a bit more.
Yeah, sure. So previously GPs may use things such as short questionnaires or risk scales to assess suicide, but that was advised against in NICE guidance, partly because a lot of these tools weren't seen as performing particularly well in clinical practice. But there's been a lot of advancements in terms of these risk prediction models, they're called, and that's been led, as Scott said, by advancements in AI as well. So technology which can use statistical methods on large amounts of data more efficiently, and perhaps that holds the key in terms of helping GPs make more informed decisions. But we're also looking at ways in which we can capture more dynamic data, and by dynamic data we mean more fluctuating or evolving data on an individual's mood or life circumstances which may lead them to have suicidal thoughts, and look at how we can capture that, how AI tools may be able to process that information and provide GPs with more decision support. So not suggesting that we're giving a GP a yes or no answer. It's not replacing the decision-making process. It's enhancing the decision-making process. It's supporting them in terms of
tools. Is it to help them make the decision?
Yeah. So there's been some work by some colleagues on what are called clinical decision support systems. So these are kind of things which are embedded in clinical practice, in kind of the computers they'll use in clinical practice in primary care, which may prompt GPs and offer them more support, offer them more insight, tell them about the available pathways which are available for a patient, and then help them make more informed decisions based on some of the information that patient may have shared previously via different types of technology.
So you're just capturing the information that the patients have already given.
It would involve having information which patients are already given, but what we're thinking about is how we capture some new information.
Additional information.
So, for example, one thing which we use is mobile phone apps which can capture information on kind of how an individual's mood may fluctuate or life events which may impact them. perhaps this information can be shared with GPs and perhaps that can inform their decision-making process.
I understand. Right. So when are you hoping to start doing this then?
We still don't have research funding, but we're working on this all the time. We're also working with lived experience experts, people with experience of having had suicidal crises in their lives, so that we make sure that those views are built into what we're trying to do. There's a way to go because we know that we've got to get this right. We've got to get this right. There's been a lot of failed attempts to make an impact in this area, and we just want to spend as long as we can developing the ideas, and then we need to persuade a funder to let us have a try. But there's a lot of developmental work still to do.
Yeah. Oh, well, thank you. That's fantastic. Thank you. Explained it, and I hope it's recorded properly.
Okay, thank you very much.
Thank you.
That's great. No, thanks for
So I'm here with Professor Claire Henderson. Thank you for coming on the research room today. So just to start us off, could you introduce yourself for our listeners?
Sure. So I work at the King's College London Institute of Psychiatry, Psychology and Neuroscience in the Health Services and Population Research Department. I'm also an honorary consultant psychiatrist at South London and Maudsley NHS Foundation Trust. And I'm a clinical academic, so I do a bit of both, basically, research, postgraduate education and clinical work.
Fantastic. And you're here today to do a presentation on your project. So could you tell me what your project's all about?
Sure thing. So RECOLLECT stands for Recovery Colleges Characterising and Testing. And this is like a 5-year programme of research that's led jointly between myself and my co-principal investigator, Professor Mike Slade, who's based at University of Nottingham. And then we have quite a big team of co-applicants who are experts in different methodologies and research assistants, very critically, to collect all of our data.
Oh, I like that, RECOLLECT. I like that name. That's a good one. And in a nutshell, could you tell us what the project is all about?
Yes, so the project is all about recovery colleges, and recovery colleges are an adult education approach to learning to live with mental health conditions. They are characterised not only by this adult education approach, whereby you're a student rather than a patient, but also everything they do is co-produced between people with lived experience of a mental health condition and people with what we call laboured experience, and that's people with professional expertise in whatever topic is going to be taught. So the management of recovery colleges and all of the kind of course development and delivery is all co-produced. So those are the two sort of key things about it. And as you can tell from their name, it's really all about personal recovery and mental health. So living as best one can with a mental health condition.
Fantastic. Oh, that sounds really interesting. And could you tell us a bit about why you're doing the project and where the kind of need for this comes from?
Yes, so recovery colleges are very, very interesting in that there are lots of them, but they have spread throughout England and a number of other countries at this point, really without any kind of central policy direction. So certainly in England and Wales, how they started was because of enthusiasts or champions, who started one and then started another, and then a lot of other places, so mental health trusts, but also like local government or NGOs decided that they should have one too. So there was no sort of diktat from Department of Health and Social Care to say, each mental health trust should have a recovery college or anything like that. So they just spread because the idea kind of made sense to a lot of people. But that's also created a lot of kind of variety and a certain lack of, really sort of widespread evaluation. So we don't really have a very good idea of what their effectiveness or cost effectiveness is like. And our funder, the National Institutes for Health Research, is particularly keen to establish effectiveness and cost effectiveness in relation to people who use recovery colleges who are also using other mental health services, so like secondary care, so using the services of mental health trusts.
Okay, yeah, so they've sort of spread out a bit, but you want to evaluate, are they really working and are they cost effective, and give a bit more of a solid plan. Is that right?
Exactly, because when they first started, like I said, there was a lot of enthusiasm and a lot of quite rapid spread across the country. But without that kind of evidence base, it means that they're vulnerable subsequently, to potential funding cuts, particularly, as a lot of mental health trusts at this point are in deficit and looking for ways to save money. So once you're no longer sort of flavour of the month, that means that you really need that evidence base to keep going.
Yeah. And could you tell us how you're doing it? So what the actual kind of methods of the project are?
Yes, so we're doing a number of different things. And one thing that you can't do with recovery colleges, since they're already there, is to do anything like a randomised controlled trial, because obviously people want to go, you can't stop them from going and say, well, you're in the control group, you've got to wait a year before you can go. So we had to think of other ways. And we have a kind of a model in mind to try and understand recovery colleges and the impact that they have. So we have to think about the kind of context in which they're operating in terms of, who the sort of host organisation is, if you like, in terms of whether it's a trust or an NGO, who's going to them. Because there's got quite a lot of variation in terms of the eligibility. Some mental health trusts restrict who can go to people who are using the services and their carers and staff, or people who have recently used services, whereas for others it's like anyone can go. So through some qualitative work that we did before this big programme of research, then we kind of established some ideas about how do they achieve their effects, and it is through things like the things that people told us about are things like, the kind of equalisation of power relationships and the sort of peer support, that kind of thing. And in terms of the outcomes that we want to look at, there are sort of intrapersonal things that people describe in qualitative work, like, feeling more confident about the future and more resilient. And then in terms of people's lives and what you could sort of look at more objectively, it's to do with how people are spending their time, really. So are they more kind of socially active? Are they looking for work or volunteering opportunities? Are they using services in a different way? So maybe hopefully less kind of crisis care. So with all of that in mind, we thought, okay, so we must look at fidelity. So given that there are these sort of principles that recovery colleges try to adhere to, let's ask managers how are they doing in relation to that. So did a big survey, did qualitative interviews of managers, and it turned out that was kind of during COVID. So we also asked them, how they were coping in COVID, basically, and how they responded to the pandemic. And then we've worked across about 34 or 35 recovery colleges to recruit people as they registered, so as they started at the recovery college, and then we followed them up for 12 months. And every 4 months we've been contacting them to fill out questionnaires, so things like resilience and hope, and also how they're spending their time and what services they're using. And those that have consented to do so, we've also got into their clinical records so we can get like an accurate picture of service use, and that helps the health economists, with this economic evaluation. We've also tried to recruit a control group. So this is where the sort of non-randomised controlled trial bit comes in. So instead of being able to do randomisation, we've gone out and at certain sites, at an NHS trust where we can recruit people who are not using recovery colleges and follow them up. But that was hard to do. So we've got a small kind of control group. Then we could match some people in terms of things like age and sex and ethnicity, and one or two other variables to create a kind of matched control group. So this is how we kind of got around this non-trial design. So then we've looked at 6 months and 12 months and 5 years before and after registering. So this is now called a controlled before and after study, which is currently submitted for publication. But we've also published a preprint because we found some positive results in terms of a greater level of reduced service use in the post period as compared to the controls. So as you can imagine, over time people do use less services, And that's the same for the controls, in general, as the people using the recovery college. But that reduction in service use is bigger if you're in the recovery college group. And obviously this is gold dust if you're a recovery college trying to evidence, that what you do is worth doing, because acute services are obviously what costs us the most in terms of bed days and emergency department visits and use of home treatment teams. So at this point, we can say, in line with the title of this conference, that an ounce of education is worth about probably £0.5 of cure. When you have all these questionnaire data and economic evaluation, service use, that kind of thing, it's also nice to talk to people because then you get a better understanding of how have you arrived at these these questionnaire, these quantitative kind of results. So we picked half a dozen recovery colleges to go into case studies. So we've got 5 recovery colleges where we've talked to a whole range of people, so not just the managers but other staff, people involved in this sort of decision making about funding the recovery college, and obviously the students at the recovery college. So we've done a lot of interviews and focus groups to try and flesh out those quantitative findings with some qualitative work. And I think one thing that's come out of that is the way in which people find this kind of education model quite something that's quite liberating, because it's very different from being a patient to be a student.
Yeah, fantastic. Yeah, we always really like to hear about the numbers, but also qualitative work. I think is always a really great source of data. Really, you get a lot of rich data from that. So yeah. Oh well, thank you so much for talking to us today, and I hope you enjoy the conference.
Thank you very much.
Welcome to the research room, Philip.
Thank you.
Hello.
Nice to be here, Jane. Thank you very much.
Can you tell me who you are and what you do?
Yes, of course. So my name is Philip Kerrigan, and I'm a researcher at the University of York in the Mental Health and Addictions Research Group. And I work primarily with Professor Lena Gager also and Dr. Lucy Tyndall, mainly on a trial called Combat that's funded by the NIHR, and it's been going for quite a few years. In fact, we're coming to the end of it now. It's starting to assess some data, and that's been to create and then trial an intervention using behavioural activation that's for young people of secondary school age, so age 12 to 18, and that can be delivered in those kind of school and other community settings by non-sort of clinical professionals. So the idea is to sort of try and pick up young people who have, they sort of mild to moderate depression, low moods, that aren't being picked up, by the NHS, because the NHS only has capacity to see the most young people and the most unwell. So to offer them this course of, I guess, about 6 to 8 sessions of this therapeutic intervention called behavioural activation. To support them.
Yeah, good. So is that why you're here at the conference today? Have you been talking about it?
Yes. Well, we've been talking about a sort of spin-off project from the main
right. So
Combat. It is Combat, but it's.
What's your spin-off project?
So it's we've developed a digital tool that can be used. So previously, there's a manual that outlines the content of our Combat behavioural activation intervention, and there are certain key components in that manual. Like we have something called a life pie, which is a sort of
life pie.
Yes. A pie chart. So it's a visualization of different areas of a young person's life, so their family, their friends, like hobbies and things, and they kind of populate that with activities that are meaningful and rewarding to them. And then the idea is that they kind of take those activities that have value for them and then schedule them into a weekly calendar, and then they kind of reflect on them and how enjoyable or rewarding or how much of a sense of connection to others they gave them, and then they'll identify, as they do more and more, what works best for them, and then they can maybe reschedule them or build on them. They might be developing goals, learning a new instrument, or getting back into a sport or something like that. And this calendar and this scheduling just helps them to, identify times in their week when they do that, so that it gives them a sense of commitment and that they, down to it.
And you think the app it helps them?
Yeah, so the app digitises elements of this manual, including that life pie chart and also the activity calendar, and in a more kind of user-friendly way, I think, than so. Instead of having to print off individual calendar sheets from the workbook, they've got all there. They can just select whatever date they want, and in this kind of app.
More for the young ones, really, isn't it?
It's that
we're all using apps these days, aren't we?
It's that digital generation, absolutely, of young people who have grown up with this, and it's second nature to them to use that.
So is it a study you're doing, or you just is it a trial you're doing?
Oh, so Combat was a trial. So the first part of it was developing this combat intervention that was co-developed with young people and carers and professionals. We did there was initial feasibility study of that. We got some promising indications that the young people liked it, they felt that it was working well for them, and so we scaled it up into a bigger randomised controlled trial across a larger number of sites.
So the app is part of that then, is it?
Yes, it will be. We didn't use it in our RCT, but we kind of developed it alongside, and the idea is that in future, hopefully, if we're still testing and developing it, but it would be something that could take the place of the sort of manual worksheets that they complete.
That makes sense. So that's why you. So it's work in progress.
It's work in progress. That's right. So we were presenting on that today, the progress, how we produced this prototype version of the app through co-producing it with our young people, experts and professionals and then sort of running this usability study where we tested it with asked 20 young people who had received behavioural activation as part of the larger combat trial to test it out for us over a number of weeks.
And have you had some feedback from that?
Yes, they know it's been positive, and they liked it, and they found it easier to access it because it can be accessed on their phone. It's always on them, so it's not a question of scrabbling for sheets and remembering where they put their calendar sheets or the other ones. Absolutely. And then there are certain features, like they score these activities if they've done them. They call these PAC scores. P stands for pleasure, A for achievement, and C for connection. And then over time, they can look at the graphs that are automatically generated from week to week, so they can see how these scores have varied. So it's again, that's something that you couldn't easily reproduce on pen and paper.
Yes. Everybody likes things instantly, don't they, nowadays?
They can see. Get sort of instant feedback.
So what's the next part of your project then?
Well, for Combat Digital specifically, we might develop the app to make it more engaging by adding sort of gamified elements. So these things, a bit like, is it Duolingo use these streaks?
Duolingo.
These kind of incentives and badges and things.
Has it got a name then, this app?
Well, Combat Digital at the moment, but it may have a more snappy name. That's right.
That's your next job.
That's the next job. Yeah, that's right.
Get a good name, a bit like Duolingo. You could have.
Yeah, we'll come back to you and let you know how we get on this next stage, and hoping to get a bit more funding to just to incorporate those suggestions that the young people who tested out made to us.
Hopefully you can come back onto the podcast when you've got further on.
Oh no, well thank you so much for having me, and my colleague, I must shout out my colleague Lucy Tyndall, who also
she had to rush off, didn't she, unfortunately?
And Professor Lena Gager, who's the chief investigator, and all the other combat team members as well. So
brilliant.
Thank you.
Thanks for chatting with me.
Thank you very much. Cheers. Bye.
Could you introduce yourself for our listeners?
So my name is Trish Darcy. I'm an applied health researcher in the Mental Health Addiction Research Group in the University of York.
Great, thank you. And what's the name of your project?
So my area of research is focused around natural environments and health. So within MARGE, it's primarily focused on people with severe mental illness. So looking at barriers and challenges for people with severe mental illness in terms of accessing and engaging with natural environments and nature-based interventions in general. But also looking at the effectiveness of nature-based interventions and green social prescribing as a community-based pathway, and looking at the particular factors that support access and engagement. So, for example, the qualities of the environment, so it might be accessibility, maintenance, safety, biodiversity, the aesthetic quality of the environment. They're all important factors in terms of supporting access and engagement.
Lovely. So what are you hoping to get out of the study? What results are you looking for, and do you have anything so far to report?
Yeah, I mean, I think in terms of all our work across natural environments and health, it's very much understanding that the provision of, for example, in an urban environment, the provision of green space alone doesn't mean that people will access and use and engage that space. And it's essentially looking at how those spaces are designed as an offer in terms of a community-based asset. So, for example, for 50% of the population who are female, a lot of the time there's challenges around accessing urban green spaces, particularly because safety is such a huge issue. So we need to look at how these spaces are designed. We need to work in partnership with communities, with the local communities where these spaces are, to ensure that they are designed for the needs of that community. So that's, I think, a really, really important thing. If we're serious about reducing health inequalities, and also if we're talking, like today, about prevention, that we need to look at what our community-based assets are, how they're designed, and are they relevant to the community that they're meant for, so that we can maximise these types of interventions.
That's wonderful.
Hello, could you introduce yourself for our listeners?
My name's Dr. Colin Palmer. I work for Birmingham Solihull Mental Health Foundation Trust with children and young people with interest in school mental health, essentially. And I also have a position at University of Warwick as well, where I've been looking at youth mental health for the last 15 years.
Oh, amazing. So, nice to meet you. Thank you for being here today. So what is the name of your project that you've brought to this conference today?
Yeah, so the name of the project is Breathe Education, and what Breathe Education has been trying to do, it's been trying to look at creating some standardised wellbeing data for young people across our schools in Birmingham. We realised that there's loads of wonderful attempts to try and improve our young people's mental health in schools, but it's often done in very siloed ways, not really linked up. We can't match the data up, different measurements. So it's an attempt to try and get some standardised data so we can look at some long-lasting trends, develop some longitudinal data, and try and understand what kind of interventions we might need to try and improve the mental health of young people going forward.
Amazing, sounds great. Why are you doing this project? So what's kind of the problem that you're trying to solve? What's the background? Any sort of literature that you've sort of basing it on?
Yeah, so it comes from originally I started work looking at psychosis, so much more on the severe end. And it always troubled me that when I was looking through working with young people, looking at their case histories, and that this isn't something that typically someone wakes up the next day and has psychosis. It's often developed over time, and that really led us to look towards, when are these early problems that young people are having, when they're developing, and that puts us in schools. And actually, when you look at the literature, a lot of the research around clinical staging models is really interesting. It shows us that mental health disorders don't just appear, they develop over time through transdiagnostic stress, with young people gradually getting ill, and really what we see in services is this breakdown at crisis point. Now, with 93% of young people under 18 in schools, then it seems like the sensible place to be trying to embed the work that we're doing and try and look at how we can work with schools to try and stop some of those trajectories towards worse health and worse outcomes for young people.
Brilliant. Sounds like such important work, so thank you so much. And what are the next steps for this project? What comes next?
Yeah, so it's a big task. What we're trying to do is we're trying to build infrastructure here. Once we've got that foundation, then we can start looking towards building in some interventions. So I'd really like to move towards that. I've actually, a lot of my personal work has been looking around the feasibility and acceptability of mental health screening in schools, and I think that's a really interesting option. But I think we've got to get it right. It's quite a sensitive issue. We don't want to be labelling young people, and also as the earlier we move away from the formation of these more serious disorders, it actually gets very murky and difficult to diagnose. So we don't want to be really doing that. So really, I would like us to get to a stage where we've got the infrastructure so that we can start putting more tailored approaches in place, for example, and work with schools so that we're bringing them with them, rather than moving straight to some kind of screening model, for example. But it's a gradual thing. It takes a lot of time. We've spent 4 years collecting data now, and we're just starting to see some of the trends and trajectories. So it's a long haul rather than a sprint towards some of this stuff. But ideally, we want a system that can provide tiered level support in schools, that can give young people timely support when they need it, at the level that they need it, and relieve pressures on services and reduce, like I say, the burden of poor mental health on young people as they develop.
Amazing, thank you.
I'm here with Elle and Pip, and you're going to tell us all about your project Primrose. So, could you introduce yourselves for us, please?
Hi, I'm Eloise Wright, and I'm a researcher based at Yorkshire and Humber ARC at the Improvement Academy.
Hello, I'm Dr. Pip Shaw, and I am a research fellow, and I'm based at University College London in the Division of Psychiatry.
Fantastic. Well, thank you for coming to talk to me. So, could you tell us what your project is all about?
So people with complex mental health conditions have a life expectancy of about 15 to 20 years shorter than the general population. And a major contributing factor to this gap is the higher risk of developing cardiovascular disease. So Primrose was developed to address this inequality. It began as an evidence-based manualised behaviour change sessions to support people with complex mental health conditions who are at risk of or who already have cardiovascular disease. It was theory-driven, through use of behaviour change wheel, and co-designed with service users, carers and clinicians. So in a clinical trial, it was found that it was really well liked, people stayed well for longer, and reduced avoidable hospital admissions. And actually it was cost saving, so compared to treatment as usual, it was calculated at saving £895 per patient per year. It's since been updated to improve the clinical effectiveness, and now it's in its third version, so officially called UCL Partners Primrose. So Primrose has 5 core components. First is a recall for annual physical health checks. Second, the full physical health check. Third, a clinical review to discuss results and co-create a care plan, and this includes medication optimisation. Fourth, and really importantly, is personalised support when risks are identified for prevention and or intervention. And this is where the behaviour change sessions sit, as well as support like peer coaching and signposting for other services. And the last bit on this pathway is the 5th step, which is the non-engagement part of the pathway. So people who aren't engaging with their care or their health check are supported to come in for their check, and also additional support, and also supported with the wider determinants of health too.
And Elle, you're now implementing this, so could you tell us about that side of things?
So we've been looking at implementation for the past 4 years, and over that time we've created a comprehensive package of support materials. So this kind of includes a full Primrose care pathway, some delivery manuals, some implementation guides, and the NHS England recommended training, which comes with kind of video playlists, e-learning modules, and an in-person lesson plan. And these are all freely available on the UCL Partners website.
Fantastic. Thank you for coming to talk to us today.
Thank you.
So hi there, my name is Aaron Wood. I'm a clinical research fellow based in Sheffield.
And my name's Stephanie Matu. I'm a research and development pharmacist in Sheffield.
Great, thank you. And then would you like to just tell us a little bit about your project?
Yeah, so our poster is explaining that people with major depressive disorder have lots of other physical comorbidities, and the risk of these other physical comorbidities is increased due to their depression, so that you can see that on the plot here.
So over the last 6 to 12 months, we've established an entirely new research clinic that we're calling the Seven Hills Research Clinic, based in Sheffield. And the idea is that it's got 2 aims really. It's firstly to recruit patients with mood disorders and related mental health problems to commercial clinical trials for new treatments for depression.
Commercial, that's interesting.
Yeah, so we work with, it's NIHR funded, so it's within the NHS, but we have commercial partners, and it's novel treatments, so some of them are psychedelic, but not all of them. But yeah, really exciting new treatment, potential treatments for depression and
so
related
would that,
issues.
for example, be like psilocybin?
Yeah, so we've got here on our poster a bit of a summary of the research that's happened so far into psychedelics. So some of the early things that were discovered, like the psychoactive effects of LSD, were back in the 1940s and 50s. And then sort of on our timeline you can see that research was stopped, it was
banned,
halted,
yeah.
Sort of the war on drugs and, you know, people kind of potentially overusing them in the 60s kind of led to a bit of a ban and a lack of interest from researchers. Well, I think researchers were interested, but there's a lot of red tape about using them.
I was going to ask, is it a challenge because it's
Absolutely,
yeah.
yeah. So as as a pharmacist working in research, part of my role is to help with the Schedule 1 licences that we need to get from the Home Office. So we need an individual licence for each of the trials that we do, and it's quite a laborious process. So we are in talks to try and make it easier. Yeah.
That's wonderful. I'd love to hear that. And then, why are you interested in this subject? What made you get involved in this?
I think basically we're in desperate need of new treatments for our patients. The long-term effects, both in physical and mental health for patients with mood disorders, is vast. And the whole everyone today will have their own perspective, but it all boils down to that really. And part of tertiary prevention, improving the outcomes for people with these conditions, is going to involve new treatments. We need to look in places we've not looked before.
Yeah, absolutely, and we are now in sort of phase 3 trials for psilocybin, and phase 3 trials have also been completed for MDMA, so we really are in the late stages of those trials, and hopefully, gathering a body of data that allows these medicines to be licensed, and we can, start getting them out to patients and implementing this research.
Fantastic. Okay, just one last question. Any thoughts about the event today?
Yeah, it's been a great day so far. Really interesting perspectives. I think what's really interesting is that people have their own, people got their own individual focuses, but it all really builds up to something that's greater than the sum of its parts. And that's there's nothing that's more, gets you going on when you're coming up against the struggles and the barriers, than to know that there are other people out there fighting the same fight.
Yeah, absolutely. There's a bit of a theme of hope, I think, isn't there? And there's that long-term plan. You can, you get stuck in the day-to-day, and in your jobs, you're sort of thinking about the short term, the next week, the next month. So to be talking about what could happen in 10 years is really exciting, because we rarely kind of get the chance to ask ourselves those big questions, really.
Fighting the good fight. Thank you.
Thank you.
And this is Jo Orchard, who organised the entire event. Thank you, Jo.
It's been absolutely fantastic.
And what's been your favourite part of it?
The favourite part, I think, just getting everybody together in a room, face to face, the academics, the support, the clinicians, NHS staff. Fantastic.
So Simon, how did it go today? Did you have a good day?
So we're here at the end of the day, and we've been thinking about whether an ounce of prevention is in fact worth a pound of cure. And I think we've demonstrated that in spades. So we've had some great conversations today. We've heard from some experts in the field. We've thought about how we can use evidence to inform this historic shift that we're going to make in the NHS from treatment to prevention. So that's really exciting. We feel as though we're at the forefront of that discussion. So we're in God's own county here. We're in Yorkshire, and I'm personally pleased that people come from all four corners of the United Kingdom to be able to talk about prevention. So we had some really great research. We've been thinking about early years. We've been thinking about working age adults. We've also been thinking about older adults. So thinking about how prevention works across the lifespan. And our two challenges are seeing if we can prevent the onset of things like depression or anxiety, or even more severe and enduring things like schizophrenia and bipolar disorder, but also trying to think about how we can mitigate some of the health inequalities that are experienced by those populations. So particularly people with severe and enduring mental health problems also experience long-term physical health problems. So we've been thinking quite a lot about how we might try to address all the things that drive those health inequalities, to try and keep physical health and mental health on the same page. One of the things that we also thought about was how things like depression and anxiety often exist alongside long-term health problems, and that's a really interesting idea that was given some discussion today. And we'd not really thought that that was the most important topic today, but it kept on coming up time and time again. So brilliant questions, brilliant engagement. We thought about the importance of co-production at the centre of this as well. So there were loads of people in the room that had direct experience of using services, direct experience of mental ill health themselves, who felt as though they were part of this conversation as we move from treatment to prevention. So that's where we are.
We've really enjoyed being here.
Yeah, we've spoken to loads of people, loads of different projects. Yeah, it's been really, really great. It's been really interesting. Great day. And thank you again for letting us come along today.
Brilliant. Thanks for your help.
Thanks very much.
Cheers.
Bye. Bye. Don't forget to like and follow The Research Room wherever you get your podcasts. And if you'd like to leave us a review, that really helps other people find the podcast.
Does it?
It does, yeah.